Pharmacist by training, and I'm the VP of Medical Affairs at T2 Biosystems. And today I'm going to talk about blood culture independent rapid diagnostics in critically ill patients. I am an employee of T2 Biosystems, and these are my objectives for today's talk. So as we've heard all morning, sepsis poses a very difficult challenge for all practitioners. We know that patients present with infections, and we don't know what those infections are. The current diagnostics have challenges. They're not perfect, and sometimes clinicians have to rely on information, and then they have to provide antibiotics empirically, as we've heard our previous lecturers. And that sometimes leads to undertreatment or overtreatment. And there is some association with potential increased mortality if we don't have the right therapy. In addition to that, it leads to hospital inefficiencies. There is more costs, unnecessary costs by using all of these excess antibiotics that can lead to a cost burden, not just for the patient, but also for the healthcare system in the country. So there are several guidelines out there to provide some guidance based on clinical literature, and one of those are the Surviving Sepsis Campaign International Guidelines for Sepsis and Septic Shock. These were last published in 2021, and specifically there are some recommendations for the diagnosis of infection. They recommend continuously reevaluating and searching for alternative diagnosis and discontinuing empiric antimicrobials if there is an alternative cause for the demonstrated illness. In addition to that, they also talk about the timing of antibiotics, and I think we've already addressed this earlier as well. It's so important to have those antibiotics, the correct antibiotics, on board as soon as possible, usually within 1 hour of recognition. Again, we saw this chart presented earlier by one of our colleagues, and we know that time is a key predictor in survival and length of stay for patients with bacteremia. For every hour delay in therapy, survival decreases by about 7.6%. So it is key to get that patient on the right therapy as soon as possible. What are the challenges with blood culture? This is what we have. We've been using this for over 80 years. This is the standard of care. We know that there are multiple bottles required. Antibiotics and antifungals can inhibit pathogen growth, especially if the patient has been administered antibiotics and then you take the blood culture afterwards. We also know that there's a contamination risk for these. From an operational perspective, there could be issues with mislabeling, slow growth, or no growth. We know some pathogens can be a little fastidious. And then we know there are also issues with specimen collection. And then it doesn't stop there. Remember, once we collect the blood culture, we have to wait for it to grow. Once it grows, we gram stain, we incubate, we manual or automatic species ID, and then finally, somewhere between 12, 24, if you're very fast and you have some of these very modern technologies, you can get some identification of the pathogen. But in some institutions, we're waiting up to 72, 96 hours for the final AST to then give that information to the clinician to modify the therapy. What if we could change that journey? What if we could provide information sooner? So what I want to talk to you today are how we can incorporate non-culture dependent diagnostics. This is directly from whole blood. So this is not going to replace blood culture, but it's going to be done in tandem with blood culture. And it's going to provide species ID or genetic resistance ID within 3 to 5 hours. Hopefully allowing the clinician to, one, modify therapy or improve therapy by knowing what that species is. This is the T2DX. It's a fully automated walk-away clinical multiplex benchtop diagnostic system capable of running tests directly from whole blood. The technology is based on an amplification, but there is no extraction or purification required. After red blood cell lysis, we concentrate the microbial cells and remove the cellular debris. Then there's cell lysis of the bacterial cells. And then, like I mentioned, the DNA amplification with thermostable polymerase and target-specific primers. These primers have magnetic beads, and that is what's going to allow the detection of a T2 signal, which is a relaxation signal within the system, and that's the method of detection. again, happening within 3 to 5 hours. These are the current panels that are available. The T2 Candida panel covers Candida albicans, tropicalis, parapsilosis, crucia, and glabrata. We have a bacteria panel with the 6 most common sepsis pathogens, including Ephesium, Staph aureus, Klebsiella, Acinetobacter baumannii, Pseudomonas aeruginosa, and E. coli. And then finally, our newest panel is T2 resistance with 13 resistance genes, 4 gram-positive and 9 gram-negative genes. And you can see there the specific sensitivity and specificity for each of the panels. They are all CE cleared for use in Europe, and we're currently undergoing a study in the US for FDA clearance for the resistance panel in the United States. I'll go over some of the clinical data. So T2 Candida has been around for a while, from about 2015. So this was some of the outcomes from the study, the Direct-1 study, which was the pivotal trial that brought the panel to market. With this study, they evaluated about 1,400, 1,500 patients. They were able to see the time to species identification was about 125 hours faster with the T2 Candida panel versus blood culture. The sensitivity, as you saw on the previous slide, 91% and 99.4% specificity. And there were about 38% more detections with T2 versus blood culture. So what we saw is the potential to detect those infections, those pathogens that are being missed by blood culture alone. The T2 bacteria pivotal trial was designed in a very similar fashion. It was a multi-center study. This time we were able to identify species within 66 hours faster with bacteria. We know that these grow a lot faster in blood culture. High sensitivity and specificity, about 90 and 98%. And again, we saw something very similar. T2 bacteria was able to identify more pathogens than blood culture. And we're going to see in some more studies that I'm going to talk about how we're able to prove that those were in fact true infections and not false positives. This is an independent meta-analysis that was published in 2021. Apologies, I don't have the reference there. But it was published in 2021. 14 studies were included. Very similar, we saw faster time to detection. We saw in 4 studies, they were able to get to the specific therapy 7 hours faster, and patients received targeted antimicrobial therapy 42 hours faster, and that was specifically for those with the T2 Candida panel. As you can see here, the results are swayed a little bit more to the T2 Candida panel, as that panel has been around a lot longer than the bacteria panel. But we're hoping and we're getting more and more data on T2 bacteria. Last year in 2022, we had 3 studies that focus on T2 bacteria and T2 Candida. So, hopefully in the future, we'll have a meta-analysis that contains more of the bacteria outcome data. And then lastly, we saw reduced length of stay in the ICU, 5 days shorter in 3 of the studies, as well as reduced hospital length of stay, 4.8 days shorter with the T2 Candida. I was told that a great number of the clinicians that were going to be here were intensive care, internal medicine, so I wanted to just show you a breakdown of the publications that we have seen in the ICU population. So this is starting from the most recent and going back to about 2019. So as you can see, it's been a mix of Candida studies versus bacteria and resistance, or Candida and bacteria. We have seen studies in the US and different European countries like Austria and Italy, where the device is in routine. Studies in Czech Republic, Croatia, Greece, Austria, etc. So definitely a lot of reference to go by. Most recently, we looked at 12 studies because we were really wanting to explore, with a panel that contains 6 targets, can we really target all of the BSI pathogens or bloodstream infection pathogens? And in fact, we can see from this analysis that the T2 bacteria panel covers up to 74% of bacterial pathogens that are causing bloodstream infections. So that's actually a pretty significant number. In some facilities, it can be higher. What about patient selection criteria? We saw this come up in a lot of the previous lectures. We heard about biomarkers, we heard about scoring systems. So I really want to touch on that and give you a little bit of insight about what clinicians are doing in order to improve and optimize this test for their patients. So again, currently it can be based on the patient type, so focusing on those patients that are categorized as having sepsis, or maybe patients in oncology or transplant wards, potentially emergency department, ICU, or surgery, wherever these patients are coming in with the risk factors or with the elevated biomarkers. In some facilities, the test has been restricted due to the ordering provider. So if maybe they're an infectious disease physician, an intensivist, or a hospitalist. We also see some hospitals looking at a combination. Maybe they're looking at a specific ward, but also looking at a protocol. So if they meet specific criteria, like an elevated lactate, procalcitonin, or so on, or for example, they've incorporated some sort of scoring system like SIRS, MUSE, or NEWS, QSOFA, et cetera, into their pathways to then allow selection of these patients. There's other things that need to be considered from the hospital perspective: the size, the epidemiology, the services that are being provided. Is there an electronic way of getting this information out to the clinicians instead of having to manually put it in the computer, then have somebody look at that, then the physician? And so that really can slow down the benefit of having a test result in 3 to 5 hours. We heard about the antimicrobial stewardship structure. Very important to have antimicrobial stewardship involved, especially when investing in such modern technology. And then clinician involvement. This needs to be a collaboration amongst all departments, including physicians, microbiology, and pharmacists, if pharmacists are included within your teams. So who to test? These are some example criteria based on the physical situation. So remember, we talked about patients having at risk for BSI, sepsis, septic shock. It could be patients with an underlying condition that puts them at risk for bloodstream infections, intra-abdominal surgery, IV drug user, febrile neutropenia. And then lastly, we just heard a talk on implanted devices, dialysis access, central venous catheters, or prosthetic valves. How would we react to these results? This is a sample algorithm that has been adapted from some of our current clinicians, some of our current users. So you have 6 targets, right? So you really want to educate the clinicians. You want to create a pathway to understand the result and know what to do with that, because the clinicians are going to call and say, what does this mean? So if you have a result that is positive for ephesium, you have to consider what the epidemiology is of the hospital. Do we have ephesium in the facility? What are the resistance risks? Do we have to escalate therapy to cover vancomycin-resistant enterococcus based on the location and based on the patient risk factors? On the gram-negative side, let's say we have a Pseudomonas that's positive. Do we have the patient on empiric anti-Pseudomonal therapy? If not, we can make sure that the patient gets that as soon as possible. So really 6 different channels, 6 different results that we can think of. What about if the test does not detect the pathogen? So basically it's telling us that we do not have this pathogen in the bloodstream. So can we rule out VRE, and can we de-escalate if there's a potential? So if you are not detecting Staph aureus in the bloodstream, do we have less concern for Staph aureus, and can we start to de-escalate therapy and maybe focus just on the gram-negative coverage? Or vice versa, if we detect Staph aureus, but we know we don't have these very concerning pathogens like Klebsiella, E. coli, Acinetobacter, and Pseudomonas, can we then back down on that therapy and focus? So this is an example of potentially some tests that are coming back from our lab. Let's assume, and this is more relevant to a hospital that I have worked with in the past, our empiric therapy was cefepime or piperacillin tazobactam plus vancomycin. In septic shock and critically ill patients, we want to cover for MRSA risk, and we also want to cover for Pseudomonas. So let's assume this was the empiric therapy. What if ephesium was resulted? Can we make a change to empirical therapy? Yes, because at this point we know that if we have a patient with a risk for VRE, we need to add linezolid or daptomycin, and potentially we can then discontinue vancomycin. Another example is, what if we have a result for Pseudomonas? In this point, we would want to potentially double cover, depending on the risk factors and our hospital antibiogram, with something like an aminoglycoside or a fluoroquinolone. And then at that point, we know that we can focus therapy on Pseudomonas and we can discontinue vancomycin. So again, the whole point with this is to try to optimize therapy and optimize the antimicrobial stewardship to decrease unnecessary use of antibiotics. And really, we can see that there is a potential to change therapy in all of the cases in this case example. So what I would recommend is that you insert your empirical therapy and see what your options would be. Know in advance how you're going to react to this, because it's going to make that process a lot easier. Switching gears a little bit, we'll talk about the T2 Candida panel. Similarly, we want to create scenarios where we would know who to test, when to test, sepsis, septic shock, prolonged ICU stay, or if they're considering antifungal therapy. In the facility that I used to work at, if we're starting the patient on antifungal therapy, then there's a huge concern for Candida infection or for fungal infection. Certain underlying conditions predispose the patient to fungal infection, neutropenic without antifungal prophylaxis, pancreatitis, GI surgery, etc. We also want to look in this case, similarly, like we did for the T2 bacteria panel, we want to look at patient risk factors. The higher the risk factors, the higher the positive and negative predictive value of the test. As you can see, the negative predictive value remains pretty high pretty much across the board, but the higher the prevalence, the higher the positive predictive value for this test. Similarly, we want to be familiar with how to respond to the test. We want to be able to have a hospital-specific algorithm on how to respond to a positive test and a negative test. So on the left, we have an example where the T2 was positive. If blood cultures are positive, then we have a diagnosis of invasive candidiasis. If blood cultures are negative, for some reason there is no growth, then we know that there is a possibility of invasive candidiasis. And we have several studies that have really looked at exploring these T2 bacteria positive blood culture negative cases, have in fact shown that therapy improved care in these patients and that in fact there was a high risk for candidemia in these patients. And then like we discussed for the T2 bacteria panel, you should be able to respond to those negative cases as well. Lastly, I want to talk about the T2 resistance panel. I mentioned there are 13 targets, 4 gram positive and 9 gram negative targets, grouped into 7 channels or 7 responses. Why are we focusing, or why did we elect to develop our third panel focusing on resistance genes? We know that BSIs caused by these organisms are life-threatening and can lead to sepsis and result in very high mortality rates. I'm not going to go over each one of these, but we know that ESBL, CRE, MRSA, and VRE really do cause an increase risk of mortality. They're more expensive to treat, and they really are a detriment to the healthcare system. I wanted to look to see what's happening here in Lithuania and just to explore what have been the challenges, the healthcare challenges with respect to resistance organisms. So I found this from the European CDC. This was an epidemic curve of an outbreak of KPC-producing carbapenem-resistant Enterobacterialis in 2019 in Lithuanian hospitals. And really what this shows here is that this is also posing a challenge for this country. So not just the southern countries like Greece and Italy and Spain, but we are seeing the risk even in countries that have low incidence, like the northern European countries, like Lithuania and other Baltic countries. But it can be potentially very crucial to identify these pathogens because they are so easily transmitted, to have an early way to identify these patients, to isolate and to treat appropriately so that we can prevent these types of outbreaks. We saw these diagrams already. I just wanted to highlight where you are with respect to the other European countries for Enterobacterialis resistance in 2020. So you see on the left CRE, not that big of a problem. ESBL is probably more concerning. And then, of course, we have MRSA and VRE. VRE looks like it's a severe problem currently for your hospitals. And then lastly, I'd like to go over how to interpret. There could be various ways, and just to give an example, hospitals are testing with T2 resistance independently, or they're pairing it with T2 bacteria, or they're using it in response to a positive blood culture. So various ways to look at this. You'll just have to determine the best way to use this in your specific hospital. So here's an example where T2 bacteria was positive with infekcijų. The T2 resistance was positive for Ven A and Ven B. The most likely pathogen is going to be vancomycin-resistant infekcijų. And then we have to think about what that resistance implication is for your specific facility. Okay, so again, we have to think about this before we start testing so we know how we're likely to respond. And we have to be able to look at discordance, because there are going to be some cases where blood culture grows nothing, but you have a resistance result. We have to be able to interpret that and provide some guidance to clinicians on the fact that if that is not a bacteria that is on the T2 bacteria panel, that's an off-panel bacteria that could still be causing infection. Here's another example where Klebsiella pneumoniae grew. This was a KPC identified with T2 resistance. Most likely this is going to be a carbapenemase. And then on the right side, we see the resistance implications. So again, knowing how to respond, being able to interpret these results is going to be crucial. So we're going to have to work very closely with our microbiology partners in the US. We work with our pharmacy partners to provide that guidance to clinicians. This is going to be very new material, especially because this information is coming back within 3 to 5 hours from the initial blood culture. Again, once blood culture results in 24, 48 hours, whatever it is, then you're going to have to do some sort of adjudication to make sure you're kind of closing the loop on the testing. So with T2 diagnostics, we know that we can enable physicians to get more patients on the right therapy faster. All of our panels are performing accurately. And again, we saw sensitivity and specificity of 90 and greater than 98%. We know that evidence shows that if you can get the patients on the right therapy faster, we can reduce mortality and morbidity. This is also something that is part of the antimicrobial stewardship program that focuses on reducing resistance, on improving care, and on reducing overall costs within the hospital. And then lastly, we know that those new resistance markers can help us detect the potential for resistance a lot faster. So with that, I'd like to thank you and open up